I'm Dr. Mark Harriman. I'm one of the orthopedic surgeons with the Memphis Orthopaedic group. We are a 12-member group in the Memphis, Tennessee area. And this brief video today is going to be on a subject that is dear to my heart, and that's the shoulder. I do general orthopedics, but I also enjoy a lot of shoulder work and as well as knee work and sports medicine type activities. Today specifically, we're going to talk about shoulder dislocations. I'm going to explain to you what that is, a little bit about the anatomy of shoulder dislocations, and some degree of how we treat it. There's multiple ways to treat it depending on the patient, as I will explain to you. The shoulder is a very interesting joint in that there is no other joint in the body that moves near as much as the shoulder joint. If you think about it, you can put your thumb or your hand just about anywhere, and the purpose of the shoulder joint is to position the hand. So that comes with a price, and anytime you have a joint that moves that much, it means that it is by definition a little bit unstable, or we could never move it as much as we're able to do. So with certain patients, that can lead to a problem called a shoulder dislocation. Now, one of the things I'd like to point out today is that I'm not going to talk about an AC separation. There is some confusion in my patients when they come in between the difference of, or with the difference between an AC separation and a shoulder dislocation. So I'm going to show you just a little bit of anatomy using this model that I'm holding. The shoulder joint is actually composed of 4 joints. The first of these is the end of the collarbone near your breastplate, and on my body that would be right here, and that's called the sternoclavicular joint. So that's joint number 1. The second is the other end of the collarbone, which is the AC joint, or the acromioclavicular joint. The clavicle is the C of the AC joint, and the bone at the top of the shoulder, which is actually part of the shoulder blade, is called the acromion. The third joint, which we don't typically think of as a joint, is between the shoulder blade and the chest wall. So that's back here in the back of the body. And then the final joint is the glenohumeral joint. So when I was talking earlier about how good the motion is, in the shoulder, I was specifically talking about the glenohumeral joint. So what happens with a dislocation? In a dislocation, an individual often falls, and usually I'll just demonstrate in this position. As we raise the arm up, that's called abduction, and as we come back this way, that's called external rotation. So we can certainly do that at any time that we want to without our shoulder dislocating, but if we fall, there are a lot of added forces that go into that shoulder joint and make that shoulder pop out of joint. Now, there's multiple ways to dislocate a shoulder, even different directions to dislocate a shoulder, but I'm just going to talk about the one that we see most commonly, and that's an anterior dislocation. The model here shows in the front some tissue along the front of the joint, and that's called the capsule. But there's some structures inside the joint that I'll show on the poster behind me that are even more important to keep the shoulder joint in place. So let's go to the poster and I'll show you sort of a normal and abnormal anatomy of a shoulder joint, the internal workings of the shoulder joint that you don't see most of the time. So if we go to this poster, this is titled Socket of the Right Shoulder Joint. What I'm holding happens to be a right shoulder joint also. And what I'd like to point out is this tissue that surrounds the socket. I didn't mention, but a shoulder joint is in fact a ball and socket joint, which means that there is a flat socket, unlike the hip joint, which is a deep socket, and a ball that sits into that socket. So surrounding the shoulder socket, or the glenoid as we talk about it anatomically, is a structure called the labrum that I just outlined. That labrum deepens the shoulder joint, allowing us to do things with the shoulder but not dislocate our shoulder. So the labrum is a very important tissue. So what happens with a dislocation, we'll move over to this one over here, and that one is called Bankart lesion. And now we see a little bit larger picture of the socket and the labrum, and down here is where the labrum has been separated from the glenoid, or the shoulder socket. And that's what happens when we dislocate our shoulder in many instances. Now, there are some instances where that doesn't happen. Derek Jeter, as most people know, is a wonderful baseball player who several years ago dislocated his shoulder early in the season. But fortunately, when Mr. Jeter's shoulder came out, he did not have a Bankart lesion, and he was able within 6 weeks to go back and play. But if you have this Bankart lesion, and you are at risk for the shoulder dislocating further. So I wanted to demonstrate on the small model here exactly what happens when the shoulder comes out of place. As we come up, as we said, into abduction, then the shoulder has a way to separate, or the ball, which we call the humeral head, has a way to separate from the socket, and that's the shoulder dislocation. Now, basically, three things roughly are going to happen after you dislocate your shoulder. In some instances, it comes out and goes back in all by itself. In some instances, you might have a friend or a family member with you and they'll put it back in for you. In many instances, though, an individual that has a shoulder dislocation has to go to the emergency room and get some degree of anesthesia, maybe an IV, and the emergency room personnel put the shoulder back in place. So it's a very painful thing when a shoulder comes out if it's your first time. And I'm sort of talking to people who might experience their first time shoulder dislocation today. Well, who are those people? Actually, it can be anyone from age 10 or 12 right on up into the 80s. And it just, a lot of times when it happens, it depends on activity level. Obviously, the younger we are, the more likely that we'll get into a sports situation or an occupational situation where the shoulder could come out of place. So let's say your shoulder has come out of place, and let's say one of those three things happened. It either went in by itself, a friend or family member put it back in for you, or an emergency room doctor put it back in for you. What happens after that? Well, the good news is about 2/3 of shoulder dislocations never come out again. So if you look at 100 people, roughly 67 out of 100 people will not have a dislocation of their shoulder again in the future, ever. So they're obviously going to do very well. But unfortunately, that also means that about 1/3, 33 out of 100 roughly, are going to have some degree of shoulder dislocation or instability of the shoulder, which means even without a fall in the future, sometimes they could have their shoulder pop out. And it does happen with sometimes very little activity. Sometimes patients will actually have the shoulder pop out while they're sleeping. So that's a very rough way to wake up. But it does happen, and we see that in the office. So what do we do for the people that come into the office who've had a shoulder dislocation? Well, first of all, I tell them that there's about a 2/3 chance it won't happen again. But what happens if it does happen again and they're in that 1/3 group that are having shoulder instability? It sort of then depends on what they do. If they're young and very active, maybe an 18-year-old football player or a 17-year-old football player who's a junior in high school, maybe thinks that he might be able to play some college ball, then we have to talk to that individual possibly about reconstructing that shoulder, doing something to make that shoulder not come out of place again. If they're older and less active, then we would almost always get an MRI. Of course, we might get an MRI on the younger patient too. As we get over 40, the opportunity for a rotator cuff tear becomes much more prevalent. And those patients that are over 40 might not have to have an operation to rebuild their shoulder to keep it from dislocating, but they might have to have an operation to repair their rotator cuff. So if you look at the statistics, it's very interesting what happens to the group that is at risk. The most risky group for recurrent dislocation or recurrent instability in the shoulder is a group between ages 12 and say 20 to 25. And if you look at those folks, even though a high number of those might have recurrent instability, only half of those patients actually eventually wind up having shoulder surgery, shoulder stabilization procedure. So if you look at all the numbers on shoulder dislocation, only about 1/4 of 100 people that walk into my office eventually wind up having surgery, which means most people do pretty well. So some people do have recurrent instability and decide that they don't want to have surgery. They're just going to make some alterations in their lifestyle or perhaps in the way that they do their job so that the shoulder doesn't pop out in the future. If we have to do surgery, there's a couple of choices. We can do an open operation, which is like making an incision, as I demonstrate on the model here, and then we go in and rebuild the structures that way. But this day and time, and in my practice for at least the past 12 years, I've done almost all of these arthroscopically, which means very small incisions are made. We go in with some special instruments while the patient is asleep and actually rebuild the labral tissue that was torn. In other words, we correct that Bankart lesion that I mentioned to you earlier. The results of this type of surgery tend to be very, very good, and the results of arthroscopic surgery are virtually as good as open surgery, which is what I used to do personally 20+ years ago. So in summary, this is a problem that I hope you never have, but if you do, you should seek medical care if your shoulder doesn't pop in by itself. And you should expect that an emergency room doctor will very easily, with some light anesthesia, be able to put your shoulder back in place. And then once that happens, I would advise you to go ahead and seek orthopedic care, and we're more than happy to see you here for that problem, and then we can explain to you what the options are once it happens. But I do want you to remember that most people, 2/3 of the people that have a shoulder dislocation, never have it come out again. And of the 1/3 of the people that do have it come out again, only about half of those eventually wind up having surgery. I appreciate your attention, and I wish you well in your endeavors.